screen. Yeah. Can you do that? See that now?
Yes, sir. Fine.
Yes, please change one slide. I'll see slide change. One slide. Yes. Yeah, it's changing. Please go to previous slide. Yeah. Fine. Everything is
good. Brilliant. How are you, Biju?
Fine. So we'll wait till 7:15 sharp.
Yeah, so it's another one. 30-40 minutes is not enough. So there is no way I can make you an expert. Hopefully, it'll give you the basics on which you can build on. It's like, the building blocks for any kind of procedure. Okay. And unfortunately, you won't be able to right. No, I always struggle with okay, good. So what I'm planning to do over the next few minutes is we will discuss about, because no point in me going straight into the ultrasound scan unless we understand why do we need an ultrasound scan. So the first few slides I'm going to cover why we need ultrasound scan because there are limitations of cross-sectional imaging. Then I'm going to go into what is an ultrasound scan, how is it different from preoperative scan, what are the uses. Uniquely this time, I've included the sonoanatomy of the liver. I'm also going to talk about the role and also the technique. Okay, so I think, as I said, we need to talk about why we need to do an ultrasound scan. But to understand the role of intraop ultrasound scan, we need to establish a few basic things. The first thing is, what makes the liver so unique? Why do we need to talk about even the intraop ultrasound scan? There are several reasons for this, and you already know. One is the dual blood supply. So liver gets about 1 to 1.5 avoid damaging things which you don't want to damage and get into bleeding. And then the other unique thing is the complex segmental anatomy. There are only a few other organs like the lung and the spleen, and the kidneys have got the segment. To plan for liver surgery, there is so much of information we need to know. So all these things we need to know. What is the background liver? If there is a tumor, what is it? Where is it? How many are there? Is liver resection feasible? And which segments you want to take them out? How many segments can you leave them behind? Do you need to do a major resection, minor resection? What is the relationship to the inflow and outflow? Relationship to the 3 hepatic veins? Relationship to the gallbladder, especially for planning for an ablation. You don't want to burn the gallbladder if the tumor is close to it, so you may want to take the gallbladder out. And then finally, how much liver you're going to leave behind. That is future remnant liver. I would like to use the word functional liver remnant rather than future remnant liver, because the quantity may be good, but the quality may not be good. So I think it's important to use the functional liver remnant rather than a future liver remnant. So all this information, we need to get it from something. And where do we get scans? Which will give you most of the information you need to decide what surgery you want to do, how much liver you want. Radiologists, you don't interpret it, and they'll give you the information. You have to interpret it yourself. I'm not good at MRI scan. I'm very good at CT, but there's a lot of information you get at an MRI scan which I won't be able to interpret it. So that's a kind of a limitation. The other thing is they're not going to be useful for you to mark the exact where the resection margins are going to be. And all taking up the entire right hemi liver, and we ended up doing an extended right hepatectomy. And look at the right side image. This is a cirrhotic liver, and you have to identify where the tumor is. I mean, it's like even with the very good, if you're a good guesser, still you won't be able to tell exactly where the tumor is. So you have to rely on something which will give you the real-time information. So we need, for liver surgery, we need a GPS, and GPS is an intraoperative ultrasound scan for you. So what is intraoperative ultrasound scan? And obviously this is an ultrasound scan done by the surgeon during the surgery compared to the percutaneous ultrasound scan. It is much more sensitive than the percutaneous ultrasound scan because you're putting the probe directly on the organ of interest, that is the liver. And you don't need any gel because the moisture on the liver surface will act like the gel and will allow the transmission of the ultrasound waves. And the frequency used for the percutaneous one and the intraop ultrasound scans are different. You use the higher frequency for the intraoperative ultrasound scan. I'll tell you in a minute why that is. And I've already mentioned it is much more sensitive. And you also have the option of different probes. So you can have a laparoscopic flexi probe, laparoscopic rigid probe. You can obviously use a T probe, laparoscopic European consensus guidelines of laparoscopic liver surgery. And it clearly says people should not be doing liver surgery without intraoperative ultrasound scan. I mean, I don't want to use all sorts of adjectives, but there is no way we would do liver surgery without intraop ultrasound scan, even if there is a tumor hanging from segment 6 or segment 5. 5 or segment 4A, 4B, we do the ultrasound scan to make sure that the rest of the liver is absolutely fine. So that is the reason why we need to do intraop ultrasound scan. And now I'm going to go into basics of intraop ultrasound scan, because I think it's very important for you to understand the basics. Without the basics, there is no way I can take you into the role of intraop ultrasound scan in liver surgery. And as I said, I take 2 days to go through this, so I'm trying to cover in obviously 30 minutes. Let's see what I can do. But whereas the intraop ultrasound scan, we use higher megahertz. We use almost in 5 to 10 megahertz unit frequency for the intraop ultrasound scan. The reason for that is the higher the frequency, the resolution of the image is much better. So you get very good quality. Because you are putting the ultrasound probe directly on the organ of interest, you are not worried about the depth. Because you can change the direction of the probe and you come from the inferior aspect of the ultrasound scan, the liver, if you want to see something on the posterior aspect rather than the anterior aspect. So you don't need to worry about the depth. What you want is the resolution, good quality images. So higher the frequency, higher the resolution, but unfortunately the depth will suffer. That if on the ultrasound scan, if it looks red, it's an artery. If it looks blue, it's a vein. It's nothing to do with the red or blue. Red and blue is nothing to do with whether it's an artery or the vein. It is to do with the direction of the blood flow towards the probe. So if the blood is towards the probe, let's say if you place, that's a blood vessel, for example, you place the ultrasound probe there, and the blood is going towards the probe, it will be a red color, okay? If the blood is going away from it, it will be blue. So remember this mnemonic, BOT, blue, away, red, towards. But most of the big blood vessels like the portal vein or the aorta or hepatic veins will have both colors, so both blue and red, because some will be going towards the probe and some will be going away from the probe. So you get what we call a yin-yang appearance. So just important to remember that, okay? Now, these terminology, when I started learning, it was so confusing, but actually it's very simple. So the terms we use are anechoic, isoechoic, hypoechoic, and hyperechoic. Hyperechoic can also be used in almost like synonymous, like a echo bright back. No, not everything is going through basically. Okay, so if you look at this tube, that is anechoic. That means there are no ultrasound waves that are coming back. Everything is going through. So anything that is black, we describe anechoic. Okay? Anything that is black. Isoechoic, when we talk about two things. So for example, this is isoechoic compared to this, because both are similar appearance. Or I can say this is isoechoic in relation to this. So you cannot describe this as isoechoic on itself. I can say this is anechoic because it's completely black, but I can't say that is isoechoic unless I'm comparing with, so compared to this tubular structure is isoechoic. Okay, I hope that's clear. So anechoic means completely black. Iso means when you're talking about two things together. Hypo means is gray basically. Okay, so this is hypoechoic. That means some of the ultrasound waves are going through, some of them are coming back. So that's gray. What about hyperechoic? So that is bright. So this is hyperechoic. Okay, that is hyperechoic, that is anechoic, that is hypoechoic, and that is isoechoic in comparison to this. Okay, I hope that's clear. Let's say, for example, this lesion here, so it's got a hypoechoic halo. Okay, is white. That's usually either bone, okay, or air. Now, why air and bone will look similar? It is to do with the properties of the ultrasound waves, and it is to do with the acoustic impedance. And unfortunately, I'm not going to have time to go through it, but just remember that if it's white, means usually it's bone or air. Air can also be completely black when there's a lot of interference because there's no transmission of the ultrasound waves as well. If it's black, mostly it's fluid. Okay, now we're going to go into the sonoanatomy of the liver. Now, one important thing I will tell you in intraop ultrasound scan is the ductus venosus, which is a very, very important landmark, and it is present between the left lateral section of the liver that is there and the caudate lobe. and this is ductus venosus, which is a remnant of the umbilical vein. And this connects the IVC to one side, one end, and the other end is connected to the junction of the right and the left middle and the left hepatic veins. So one end is connected to the portal vein at the junction of the horizontal and vertical portion, and the other end is connected to the IVC at the junction of the middle and the left hepatic vein. On ultrasound scan, it will look like a nice thick echobright layer. That is the ligamentum venosum. If you trace one end, that will take you to the portal vein. If you trace the other end, that will take you to the IVC. Now, in real life, if you look at the right-hand side picture, so that is the ligamentum venosum, which is in continuity with the lesser omentum. That's the caudate lobe at the back, and that is the left lateral section of the liver at the front. Different way of showing again. So that's the round ligament is attached to the blind end of the portal vein. That is the ligamentum venosum, just in front of the caudate lobe. And this is a very, very important anatomical landmark on intraop ultrasound scan. And that is a technique I teach. We've actually labeled it as Aruri's ligamentum venosum technique. We're in the process of publishing that technique. On intraop ultrasound scan, if I play the video, hopefully it will play. So that's the caudate lobe, that is the ligamentum venosum. If you take one end, you can see the left middle hepatic veins. And the other end, that is the portal vein. So this landmark is always there in every single patient without fail. There may be slight variations, but it is there. So that's why I do not use any other landmark, because there are variations in other landmarks, like the middle hepatic vein, like the gallbladder, like the portal vein. But in terms of the anatomy of the liver, few anatomical landmarks. One important landmark I've already mentioned, that's the ligamentum venosum, behind which is the caudate lobe, behind which is the cava. And then obviously, if you go close to the diaphragm, you'll see the hepatic veins, left, middle, and the right. And that's the gallbladder, that's the middle hepatic vein where it starts. And if you go close to the hilum of the liver, then obviously you encounter the portal flow. So now I'm going to talk about how do you identify whether it is a portal vein or hepatic artery, hepatic vein. I'm going to give you certain characteristic features by using which you can tell whether it's a portal vein, hepatic artery, or the hepatic vein. So portal vein is a black tubular structure, so it's anechoic, so as the hepatic vein, so as the hepatic artery. But it has got an echobright white thick layer, that is the Glisonian sheath, which goes inside the liver along with the portal structure. So if you see a black tubular structure with echobright thick white layer, that is most likely portal vein. You can also identify the portal vein based on the branching pattern, because the right divided into two, left has a horizontal extrahepatic portion and a vertical portion. Vertical portion ends in umbilical fissure, and the blind end is attached to the ligamentum teres, and the junction of the horizontal with the vertical portion will be the ligamentum venosum, or ductus venosus. Then you press the button color C, that will give you the red and blue signal. But the most important feature is this, that is the Doppler pattern, that is positive and flat. If you see a positive and flat wave with the echobright layer, with the typical branching pattern, that is the portal vein, unless proven otherwise. Okay, I hope that is clear. Now you can see here, so that's a vertical portion of the left portal vein, that's a horizontal portion, and that is starting with the right side, and you can see this echobright layer. Okay? See again, the right is dividing anterior and posterior here. Again, you see the thick echobright layer. Unfortunately, you can also see that for the hepatic veins close to the diaphragm and also the bile ducts which are inflamed. Normally, you don't see the bile ducts inside the liver on ultrasound scan because they'll be always kind of not visible. But if they're dilated and they have got cholangitis, you will see something like something like this. But that's where you need to use the color button, where you have the color inside the portal vein but not on the bile duct. And then if it's a Doppler wave pattern, it's positive and flat. So this is the typical portal vein, that's positive and flat. If there is if it is not like this, and if all the other features are telling you that it's a portal vein, that means it's abnormal. So another video here, let's see. So that's the CBD, that's the cystic duct, and that's the portal vein. And as I said, it's a typical yin-yang appearance. I won't move fast forward because it can stop. Okay, so that is the portal vein, all right? You can see the both red and blue. and then you press the Powell Doppler pattern, and you see that positive and flat because there are no really changes with the respiration, and it's a low flow system, so therefore it is usually positive and flat. And that's the hepatic artery, the typical triphasic pattern. You can see the difference between the artery and the portal vein. Another video here. Okay, so that's the portal vein. But now the latest ultrasound machines are so sensitive, they will also pick up the arterial pattern as well. So that's not abnormal, okay? So you can see the mostly positive and flat, but there's also a typical kind of bit of a triphasic pattern because it's picking up the arterial flow. That is not abnormal. But if you see that much high peaked portal pattern, that means it's arterialization of the portal vein. You see the cirrhosis. So again, another one that's normal. This is not normal. See here, this is cirrhotic. This is called what I call an arterialization of the portal vein. So you can tell by the Doppler wave pattern whether the portal vein or hepatic artery is normal or abnormal. Okay, so that's the portal vein. What about the hepatic vein? So hepatic vein is also black tubular structure, but it hasn't got echobright layer unless it's close to the diaphragm. And the branching pattern is different because it's got 3 veins, but if you take the anatomical variations, there are lots of variations. Its location is close to the diaphragm, and left hepatic vein invariably joins the middle hepatic vein, and ductus venosum is attached to the junction at the left and the middle hepatic vein before they join the cava, and the color signal is like the portal vein. But what is different to the portal vein is a periodic wave pattern. It follows the right atrium and ventricle. When I say periodic wave pattern, this is the wave pattern, periodic. So you have 1 positive and 3 negative, whereas the portal vein is positive and flat, P and F. Whereas the artery vein has got a periodic wave pattern with 4 waves, 1 positive and 3 negatives, because it follows the right atrium. Another picture, same thing. Okay, and also obviously location where they are. If it's close to the diaphragm, you see 3 veins, that's hepatic veins more than the portal vein. And again, see a different branching pattern. Okay, now see this one, this is a normal one, but in this case, this is one of the patients I've operated, where the middle hepatic vein is compressed by the tumors, huge tumor compressing the middle hepatic vein, and look at the Doppler wave pattern, it's all positive, there's no negative wave pattern. So you know, based on this, it is obstructed, and then obviously you need to take the necessary precaution when you're resecting it or when you're trying to dissect it off the tumor. So just a video, again, see, that's the ligamentum venosum, that's the IVC, and you can see the right, middle, and the tumor is the junction of the middle and the left. And there may be an accessory middle. See this branch? So that's one there, that's the left, and that's the portal vein, by the way. You can see that the distance between the inflow and outflow is actually not far. It's very, very close together. So looking at the pattern, you know whether it's hepatic vein or not, but obviously I've given you other information which will help you to decide. What about the hepatic artery? Unlike the hepatic vein and the portal vein, is a small tubular structure. Obviously, the location is close to the hilum, and you know, depending upon the variations, it's got a different anatomical relationship to the inflow. But in terms of the color signal, it's usually red because it's tiny, and the artery usually, depending upon where you place the probe, it's red, but it can be blue as well. So don't remember the BOT mnemonic. But the Doppler signal is positive and triphasic wave pattern. So I use the word periodic when it comes to the hepatic vein, but when it comes to the hepatic artery, is triphasic wave pattern. Although it's all positive, no negative. So this is the table which compares. Again, please, you can have a look, but in terms of remembering things, the portal vein, hepatic artery, and the bile duct. So all of them are anechoic black tubular structure. But the portal vein has got a thick echobright layer around it, so has the hepatic vein close to the diaphragm, so has the bile ducts. All of them have the color except the bile ducts, but the important thing is the Doppler wave pattern. Positive and flat is the portal vein, periodic wave pattern is the hepatic vein, triphasic wave pattern is the hepatic artery, no wave pattern in the bile ducts, okay? So that's a table which is the summary of all the different ultrasound characteristics of various structures. Now, this is a technique I use. I'll go through this again later on. So what I do is I'll divide the falciform a little bit, and I place the probe at the junction of segment 3 and segment 4B. First, I identify the ligamentum venosum as echobright layer, and then I trace the one end to the portal vein, identify the horizontal and vertical portion of the left portal vein, and trace all the branches to their destination. So that is segment 2 branch, 3, 4A, 4B. And then I'll come back to the horizontal portion, identify the caudate branch, and then move on to the right side, and then follow the right anterior sectional vein and right posterior sectional vein till to their destination. Then come back to the ligamentum venosum again, trace the other end to the IVC, left and the middle hepatic veins, and trace the left hepatic vein, trace the middle hepatic vein. And then once I finish, go back to the insertion of the middle hepatic vein, move a little bit to the patient's right, and then trace the right hepatic vein. So this is the systematic approach I use so that you don't miss anything. And you repeat it after you mobilize the liver. Okay, so that's about the various terminology in terms of the ultrasound scan, how it works, and the particular areas. It's impossible to tell where the tumor is unless the ultrasound scan is done. This patient had a tumor in the caudate lobe, and you can only see in the intraoperative ultrasound scan. I will also use it to identify characterize the liver lesion. This is the typical echo bright discrete lesion, that is the hemangioma. This is the patient I've operated. We did 2-stage resection. For the first stage, I cleared the tumor from the left side, but this lesion was there on the left hemiliver, and I was pretty confident that's hemangioma. I didn't resect it, did the mini alps, and went back on 2nd-stage resection. We left that tumor alone. If we had to do that, we would have taken out more of the liver. That would have affected her FLR. So it's important to use ultrasound scan to characterize. But you shouldn't be doing this because ultrasound pre-op imaging should have given you that information. But sometimes even MRI can overcall or undercall the hemangiomas. So it's important for you to do the ultrasound scan. Sometimes you can have hemangiomas or tumors together, so you need to know how to differentiate both of them. So it's important to understand the characterization of the liver tumors on ultrasound scan. The other reason I used is to confirm the size, site, and the number in relation to the inflow and outflow. I showed you this picture, and I mentioned about the tip of the tumor bug phenomena. And look at this one here, okay? So that's the ultrasound scan, and look at the size of the tumor. It's massive, okay? And relationship to the inflow. That's the portal vein. So if you want to do the ICG, because that's a part of my topic, is you can literally inject the ICG, put a needle on the ultrasound scan guidance into that portal, and you can inject the dye. And all the segments that are drained by that portal system will get staining. Unless you identify the portal branch going to segment 8 in this case, then you can obviously stain the segment 8 itself. But here the tumor is massive, so you probably need to stain the entire right hemiliver. And you can also use ultrasound scan to assess the kind of relationship to the intravascular structure. So look at this tumor right in segment 7. So I thought it is very close to the right hepatic vein, but you can see there is a portal branch here. You can see that? That's a portal branch. And there is another hepatic vein here. So it's literally large between the 2 hepatic veins. So one quite posterior, and one is in the normal, in the accessory position. So if you want to do the non-anatomical resection, you need to make sure that you're not going to damage these 2 things close to their insertion. And pre-operative imaging showed that the tumor is basically, this might shut down the program. Let's see. So that's a small tumor. Plan was to do a left lateral resection. But when we did the intraop ultrasound scan, okay, the tumor was much bigger. It was involving the left portal vein. That's the left portal vein. It was also involving the left hepatic vein. So we ended up doing a left hepatectomy. Now you could ask, well, maybe the gap between the MRI and the ultrasound scan is actually much longer. I promise you it wasn't. It was literally a few weeks. But intraop ultrasound scan is the key here because there's a complete change of plan from left lateral to left hepatectomy. Another patient where the MRI scan was literally a few days old, it missed completely 2 tumors. So here the plan was to do 3 wedge resections, 2 from the left, 1 from the right. But when we did the intraop ultrasound scan, there were 2 tumors next to each other, these 2 tumors, okay? Next to the left hepatic vein, completely missed on MRI scan. And I went back and spoke to the radiologist. They said, no, we can't see it. Maybe because they're next to each other, almost like they're mirror image, and they're not that big, okay? They look big on the ultrasound scan, but they're actually probably about 1.5 to 2 centimeters. So again, from wedge resection to a left hepatectomy and a wedge from the right side, complete change of surgical plan. There is no way how anybody can say, oh yeah, we've been doing this surgery without ultrasound scan for a long time. Well, I'm sorry, you're probably doing the wrong operations on the patients with high incident of R1 or even R2 resection where you left the tumors behind. Or they come back because you do an MRI scan follow-up and then they come back, oh, there is recurrence. But actually there's not recurrence. It was already there. We just missed it. Now, this is an example which, this is a case from India, actually. This was when I was in Jaipur. And after the course I did, they said, sir, can you come and help us because we got the machine. So I went into the theater. The plan was to do a right appendectomy for this guy with cirrhosis, and I do everything laparoscopic or robotic now. So there is no way of doing open, but they were planning to do open operation. But it gives you the same information. So this is the tumor, and the plan was, as I said, right appendectomy in a patient with cirrhotic. But look at this. That's the middle hepatic vein with the tumor thrombus. Okay. So that's the vein, and I hope you have seen the tumor. Let me play this again. Okay, that's the tumor thrombus. So there's a tumor thrombus in the middle hepatic vein, and the middle hepatic vein was not supposed to be involved on the preoperative imaging, but of course, obviously it is involved. So there is a complete change of plan. They were planning to do a right appendectomy, which would be the wrong thing to do because you need to do an extended right, place where there is a thrombus in the vessel. That is a very poor prognostic factor sign. So that's basically make sure that the flow to the remnant liver is absolutely fine, because I had one disaster where the stapler moved to the left portal vein. It caught the left portal vein, narrowed it, and we ended up doing an open operation because the left portal vein was thrombosed. Because remember, portal vein is a low flow system. It will not tolerate any narrowing. So since then, I make sure that I document it. I do the assessment of the flow to the other part of the liver. So this is a laparoscopic right appendectomy. I've got a sling around the right portal vein, and I'm going to do the ultrasound scan of the left liver, make sure the flow to the left liver is absolutely fine before I ligate it. I've also stopped using the stapler because that's happened after the staple moving to the left side. So I usually now tie and hemolog so that the stapler can't get through the hemologs. So if you look at the ultrasound scan, that is the left portal vein, and you can see the thick echo bright layer and yin-yang appearance. And then if you put the color signal, the power Doppler, and you'll see the positive and flat. So I know that the flow to the remnant liver is absolutely fine. I also do this at the end of the operation, and I document it, so I don't get a call. If I do get a call from theaters, I know that it's all documented, it's absolutely fine. Sorry, ITU I meant. Okay, so that's assessing the flow to the liver. I use the ultrasound scan for intraoperative ablation because
Doctor, another 5 minutes more.
Yeah, I'm nearly there. Patency after the anastomosis, and also the portal venous patency, thrombus in the hepatic veins, thrombus in the portal vein. And if there is an issue, you can correct it there and then if it is possible. So I think ultrasound scan is very useful in liver transplantation. What about in image-guided surgery? So ultrasound scan is a must if you want to do the staining of individual segments and to take out the individual segments separately for liver surgery. So the fluorescence image-guided surgery can be used for negative staining and positive staining. It also used to identify the liver tumors that are missed on the preoperative imaging. But let me tell you this, ultrasound scan, fluorescence image-guided surgery is a complementary to the ultrasound scan. It is not going to replace the ultrasound scan. You can take it from that me. We just as a complementary to the ultrasound scan, we still have not seen a big difference in terms of the R0 versus R1. But it is a small randomized controlled trial. So ultrasound scan is useful to identify the portal segments, portal branches, and through which you can inject the dye into that particular segment. So this is a positive staining technique where you literally inject into the segment which you want to take it out. But you can also ligate the branches going to that segment, and then you inject the dye into the systemic circulation. Then you can see all the other segments except that one. So that's called negative staining. So that's where the ultrasound scan and fluorescence image-guided surgery come together. So that's the ultrasound scan probe, and you can put the needle and ultrasound scan guidance and inject the dye directly into the portal branch supplying that segment. So I'm not going to go into the technique, we don't have the time, but just remember this, that is the systematic approach to the liver ultrasound scan. So I've already gone through this, but that's the kind of system I use. So just to summarize, for me, the ultrasound scan is the third arm. It's very sensitive and specific from the right side. I usually use the mid-clavicular port for the ultrasound scan placement, okay? For the left-sided surgery, it's again the left mid-clavicular port. But if it's a left appendectomy, the right mid-clavicle port will be absolutely fine. If it is pancreatic surgery, it's a completely different port positioning. But for the liver, usually either right midclavicular or subumbilical. If it's a left lateral, left hepatectomy, again, right midclavicular port will be fine.
Yes, sir. Can we have any other questions from the audience?
How to differentiate between the portal vein with arterialization and hepatic artery ultrasound IOUS. Okay, so if it is a portal vein which is arterialized, you usually still have almost a part of the positive and flat wave, on top of which you will see the triphasic wave pattern. So you have the combination of the positive and flat and the triphasic, whereas the hepatic artery is purely triphasic. There is no positive and flat portion on hepatic artery. On ultrasound scan, sorry, yeah. I hope I answered that question.
Yes, sir, that was very. I think we'll be done with our discussion session, sir. And thank you so much for an elaborate talk. Thank you so much.
Thank you very much, guys. Have a nice rest of the day. Okay, bye.
Thank you.
Thank you.
I urge all of you to actually, we do a full day session for the intraoperative ultrasound with hands-on. I think we're planning to do some more sessions next year. We had one of the first ones in Amrita, Faridabad. I urge you to join the full day because I think with the hands-on, the fun.
Yes, sir. Yes.
Okay, right. So I think one of the reasons it's been that despite knowing that the advantages of a lap in HPB, especially for instance in places like donor surgery where a patient doesn't really need any surgery, and if we can somehow minimize it, it's much more important to get all those faster recovery and all those things. The fact that some of these surgeries are in tough locations, you don't really see the portal vein tunnel in when we are doing open surgery, but in lap, in minimally invasive, you can actually go and see the tunnel. You can see any abnormal veins and all that. So the visualization enhancement which we normally use with loops and all that can be can be a big huge plus when we use the high definition cameras and all that. Even for the liver, the posterior, with flexi cameras and stuff like that, and these things are changing at a rapid pace. So by the time you guys are mature through these surgeries, don't feel guilty about not being able to do the entire gamut right on day one. Things are getting better and things are going to be easier for you guys as you go along, as the years pass by. So despite that, I think main reason why this whole challenges in HPB hospital in Faridabad. So the importance is it allows for safe dissection, effective hemostasis, and minimizes tissue damage, and thereby contributes to fewer complications, better patient outcomes, and faster recovery. But it's very important, because of the number of tools available. It's very important to use the right tool for the right job, because the potential to cause harm is equal. When many of your patients come and tell you we want laser surgery, and those of you who were not there, we were at the vanguard of this, just been adventurous and excited about it. So what I hope to actually do with this is more to excite you than to give you specifics, because I think once you figure out, you're going to teach me, another couple of years, what is the best way to do this, as I've been learning from all my juniors all these years. So then we have the specialized instruments, which includes the laparoscopic ultrasound probes, articulating instruments for difficult angles. You have a variety of these probes and things which can retract, the gold finger and all the other retractors that you can use. For suturing, you need to be familiar with all the use of a Foley. My colleagues at Cochin who do the liver transplant for donors, they were the largest centers for robotic liver retrievals. So for doing the robotic Pringles, they actually use this, I don't know if you got that. They basically thread the Foley through that, cut the tip and thread it through that, and it's all, or you can use a cotton but there's a snip and you can just put a clip there. So it's a very useful tool. Once you master it outside, you can very easily ad-lib and use this anywhere you want. So like this, I'm sure you guys are going to develop. Please, tell us also when you find something exciting. But you can. The point I'm trying to make is, do not worry only about what is available. Keep using your brains. We have in HPV, we have some of the best brains in the country. So I'm sure all of you guys are going to tell me in the next month or so how you did that, and it'll be very useful. Something just like this can be done to use it for the Pringles. The single most important things that you need to master for specific for lap liver, but also for pancreas, is the dissecting and hemostatic tools, and a whole variety of available depending on which layer you want to go. Using ultrasound, using multi-probes, stapling devices, CUSA, or a variety of combinations can be there. So the basic workhorse is the electrocautery. So you need to master that. If you have a handheld or you have a foot control, I would suggest for the electrocautery, if you get the perfect hand control, it's really worthwhile, because there are too many foot devices. So unless you're Durga or Kali with multiple legs, it's going to tool for surface coagulation. In fact, I find this better than argon beam coagulator, which became so popular in the West. So very important to know how to use it. So practice this in open surgery. So important thing is, I see many of you use sprays liberally. Please don't do that. Use that only in a very specialized setting. Don't use it for all, because there's much more thermal spread. So it's much more superficial, and the spread is there. But in lab surgery, not just HPB, this would be the one to actually master, because you can use this as a dissector as well as a cutter. I find the water jet one of the best tools, because you must have used water jets as using syringes and a variety of these needles. Some people cut off the needle line. So finally, it's the radio frequency ablation. You're familiar with that for liver tumors and all that. But this can be used, so very high frequency alternating current in that range. You place the electrode near the vessel, or tumor if you're using it for tumor ablation. So, but for laparoscopic use, Habib, this British surgeon actually used 4 bipolar RFA for bloodless feed. So I'll just show you a diagram, because I found this the most brainless, not brainless, but the easiest thing to actually use, where you don't need to use your brains to divide it. So I would recommend this only for, where you can see an obvious tumor hanging from, cystoperistectomy, or an obvious tumor which is hanging from the edge, and you just need to go reasonably non-anatomically from the thing. So just to show you, the cost is up, but if you see this, I don't know if you can see this, and I'll just show you a blown up part. So probe is very, very simple, and so basically it's got these set of 4. So it coagulates everything in between, and then the knife comes and cuts through. So it's completely brainless. You just put it into the tissue, cook it, and the knife will come and divide it. So even for open surgery, you can use a similar thing if you want to practice for open surgery. But for it's a easy tool to use, and just divide. Just keep doing it like that, and you're done without even looking at any vessel. And this is fantastic for even up to the hepatic vein branches as well. So I don't recommend that. I just wanted for sake of completion. And if you going to do only one-off once in a year or something, I'm not sure it's worth procuring it just for that. But if you can get it in the itineraries, many of these devices you can actually rent and use rather than buy for the hospitals or the harmonic. So you can use the ligature kind of devices as dissector also, like that. When you find something, you can actually use that as a crushing thing, and once it's done, sonocision also can print.
Yes, sir.
Okay, you couldn't see the entire video?
We couldn't see the entire video, sir.
Okay, so I'll just show you a representative bit. You can actually, so this is the bits. You can actually use the bipolar kind of devices or the harmonic kind of devices like this, the bipolar, and you can dissect around. So I'll just quickly show. So then there's a change of instrument. I think it's the QSA kind of device which will come in. So that's the QSA. So you can, where the hepatic, that's hepatic venous kind of thing is they're the most fragile. So you can actually rip it off, and you don't want any danger in lab. So you can dissect around the vessels and all that, and once you feel you got around the vessel, if it's handleable, whether you want to clip it, suture it, staple it, whatever you want. So a variety of tools can be used. So there again you need. So it's now completely separated, and you can now divide it with that. Okay. So I think we can.
Thank you so much.
Yeah.
Yes, sir.